and invited guests from other departments and programs to the Department of Psychiatry Grand Rounds, and also welcome you to the 7th Annual Telemental Health Conference that the department has sponsored annually. The timing for this couldn't be perfect in the sense that, as we all know, we're in the middle of a world pandemic, but also at a time where insurers and politicians have realized that access to care has not only been preserved, but enhanced by telehealth services. At the same time, the Maryland governor and legislature is moving and on the cusp of preserving the open up access to care that individuals have even beyond the pandemic. This will enable us and for patients to deliver care in a person's home or in a place at a time and in a way that meets their needs. So it is a very exciting time. And again, I welcome you all. And with that, I would like to turn it over to Dr. David Pruitt, who is the medical director of the Department of Psychiatry's Telemental Health Program. David?
Thank you, Jill, for all you do in support of the broad range of teleprograms, video and telephone across our department and state. We appreciate that. I do want to welcome everybody to the 7th Annual Telemental Health Conference. This year we are doing the conference totally online, although we will have more than adequate time for discussion. Dr. Khan will give her formal presentation and then take questions until 1:30. Kelly Coble, Program Director for the Department of Psychiatry Telemental Health Program, will facilitate the questions and discussion. And Rob White, Director of External Affairs and Business Development for the department, will close the program at 1:30 promptly. I do want to thank the entire Tele team for their help in making this conference happen, including the planning committee, and a special shout out to Anna Whitney, who takes the lead in bringing this conference together. We appreciate that. Now, moving to Dr. Khan's introduction. It is my pleasure and privilege to introduce my friend and colleague, Shabana Khan, a national authority on legal and regulatory behavioral health. Dr. Khan is assistant professor and director of telepsychiatry for the Department of Child and Adolescent Psychiatry at NYU Langone Health in New York City. Dr. Khan is an expert in undergraduate and graduate medical education and training in telemedicine. She is Director of Medical Student Education and Telemedicine at NYU Grossman School of Medicine. She is co-chair of the American Academy of Child and Adolescent Psychiatry's Telepsychiatry Committee and a member of the American Psychiatric Association's Telepsychiatry Committee. Through her active involvement and collaboration with the American Telemedicine Association, the APA, the Academy, and the Center for Telehealth and eHealth Law, Dr. Khan has helped inform telemedicine legislation, policy, regulations at the local, state, and national level. Dr. Khan received a BA in neuroscience from Barnard College and an MD from SUNY Downstate College of Medicine. She completed general adult psychiatry residency and child and adolescent psychiatry fellowship at Western Psychiatric Hospital of the University of Pittsburgh Medical Center. Dr. Khan is board certified in general psychiatry and child and adolescent psychiatry. She is a fellow of the American Psychiatric Association and a distinguished fellow of the American Academy of Child and Adolescent Psychiatry. Today, Dr. Khan will be presenting on telepsychiatry, legal and regulatory considerations. Please welcome Dr. Shabana Khan.
Thanks so much, Dr. Pruitt, and I wish I could be in person with all of you today. And I see Dr. Brooks as well, who's also on our ACAP Telepsychiatry Committee. So great to see familiar faces. So I'll bring up my slides. I don't have any disclosures. Just wanted to mention that everything that we'll be talking about today is for educational purposes, so not legal advice, but otherwise no disclosures. Our learning objectives for today are to discuss 3 legal and regulatory considerations relevant to the practice of telepsychiatry, describe how telepsychiatry privacy and safety considerations can be applied to clinical practice, and identify flexibilities at the federal and state level that have facilitated the practice of telemental health during the pandemic, as well as, importantly, opportunities for telehealth advocacy. I'll start with a brief history of telemedicine, discuss licensure, informed consent, controlled substance prescribing, general prescribing through telehealth with a focus on controlled substances, some key considerations with malpractice and credentialing, privacy and security considerations, both environmental and technical or data privacy, how to navigate safety considerations that may come up during a telemental health encounter. Though this isn't my focus, I'll touch upon some reimbursement considerations since we've seen so many changes and flexibilities during COVID-19 as we're thinking through advocacy and which changes would be appropriate to continue long term. And then I will talk about the pediatric telepsychiatry curriculum. So we developed this in collaboration with Dr. Sandra D. Young, who is at Harvard Medical School, and a subgroup of our pediatric or our ACAP telepsychiatry committee worked on this with Dr. D. Young, and it's for graduate medical education and continuing medical education. And then I'll touch upon telemedicine advocacy. So history of telemedicine. Does anyone know what this device is on the left? And you might be able to send a response through chat if anyone has any guesses. And I think Heather and Mark, a close second, won this. So it's a telegraph, that's correct. So this is an automatic telegraph receiver. It was patented by Samuel Morse in 1837. I saw this in the National Portrait Gallery in DC back in January 2020. An electrical telegraph was a point-to-point text messaging system. It was the first electrical telecommunication system. It was devised to send text messages more rapidly than written messages could be sent, and it allowed for communication to occur without necessitating physical transportation. And the history of modern telemedicine, as we know it, was kicked off by the inventions of the electric telegraph and the telephone. And then this image on the right is on the cover of Radio News magazine. This was in 1924, so almost 100 years ago. And this image depicts a television and a microphone for a patient to communicate with their doctor. And it also included heartbeat and temperature indicators. So this was kind of foreshadowing, looking at what the future of telemedicine would look like. And around this time, most US households didn't have a television, and radio was just starting to gain traction. So this was really ahead of its time. So this is our first, I didn't mention this at the start, but we have a few polling questions throughout the talk. So I will pull up the poll now, but this is the first question. While I do that, if you can take a look, and then I will launch the poll. and I'll read it first. So the first uses of telemedicine to transmit video, images, and complex medical data was that in 1939, 59, 79, or 99? So I've opened the poll now. We'll leave it open for about 30 seconds and folks can respond. We've got about 60 responses, so I'll close the poll soon. All right, so we have about 20% of folks that said 1959, and then that was the leading answer. 14% 1979, some folks said 1999. So those that said 1959, you're correct. So in 1959, the University of Nebraska used two-way closed-circuit microwave television, and they used this to transmit initially neurological examinations across the campus to medical students. So they had a neurologist conduct a teleneurology exam to teach medical students how to do an exam. And they then had a psychiatrist provide group therapy and other treatments, consultation liaison psychiatry using this closed circuit microwave television. And then they used it for additional things like including education, virtual family visits. So the image down below here is Nebraska Psychiatric Institute. And they use this technology to connect with Norfolk State Hospital, which was 112 miles away, both for assessment, diagnosis, treatment, and then also for family visits when family members couldn't travel the distance to visit. And this is considered the first case of real-time telemedicine consultation. Shortly after that, as we look from rural to urban practice, in 1967, Massachusetts General Hospital opened a medical station at the Logan Airport at Gate 23. And initially, the reason why they thought this might be helpful was because a few years prior to that, there was a plane, a small plane that had actually crashed after some Starlings flew into the engine, and the plane fell into Winthrop Bay. Some folks died on impact, but there were some that survived. But when individuals in Boston heard about what happened, they were all driving up to the scene. So emergency personnel couldn't get there. So MGH wanted to open a medical station at the airport to take care of any emergency or urgent situations that may come up with passengers coming through the airport and employees as well. So this image on the left is one of the emergency medicine physicians connecting with the Logan Medical Station using similar technology to what the University of Nebraska was using. This is Dr. Kenneth Bird. He was the first director of the clinic, and these are nurses at the Logan Medical Station. And there was a famous writer that was a medical student at this station in the 1960s, and he wrote about it in one of his books. And he described it as a clinic where the doctor's stethoscope is 3 miles long. So who was that? Now we'll launch the poll. got 20 seconds. The poll should be closing. All right, so 20% Michael Crichton. That was the most popular response, so that's correct. This was the author of Jurassic Park, who was also a medical student at Harvard at this time. So I just wanted to briefly mention our experience at NYU Langone. So in 2019, across our institution, we have 3 campuses. So across our specialties, in 2019, we had a little over 10,000 video visits. And during 2020, we had over 1 million. Within our Department of Child and Adolescent Psychiatry, so NYU has a completely separate child psychiatry department from adult. We had about 2,300 video visits in 2019, and then up to 55.6 thousand in 2020. And depending on our site, much of our practice is still virtual in many of our outpatient practices. So before I discuss legal regulatory, just wanted to cover some of the terminology since it is relevant when it comes to payers, legislation, regulations. So there's real-time technologies, which are synchronous, and then store and forward, which are asynchronous, not in real time. And then with synchronous, there's visits and consults. So a real-time or synchronous visit would be, for example, an interaction between a physician and a patient in real time using video. Consults would be clinician to clinician in real time. And then there's asynchronous. Asynchronous visits, for example, e-visits would be an example, would be an online exchange of medical information between a healthcare professional and a patient. And then asynchronous consults. So for example, consults and second opinions, which would be an online, not in real time exchange of medical information between 2 clinicians. So prior to COVID-19, what were some of the hurdles? And this is just to name a few. So practicing across state lines, licensure was a significant hurdle. It continues to be. We have some flexibility state by state, but there are still some restrictions. And then restrictions related to geography. So many payers would limit payment only if a patient is in a health professional shortage area or outside of a metropolitan statistical area. There were restrictions on the type of site that the patient would have to be in at the time of the visit, depending on the payer or the state. The types of practitioners that could be reimbursed for telehealth and the services covered. I mentioned prescribing, which we'll talk more about. Reimbursement was one of the biggest, if not the biggest, barrier. And then there's also clinician and or patient comfort with the technology, experience with the technology, clinician education and training, which is why our Telepsych committee has been working on this curriculum and reaching out to ACAP members. And then health disparities, access to technology, access to network connectivity. And then it's not just the technology and the internet itself, but also the steps needed in order to set up the equipment or the technology to connect to a visit. So when telehealth is done well, we can address a lot of these health disparities, but we also want to keep in mind that we can actually further widen them if we're not thinking about these issues. So a lot of changes have been made to laws, regulations at the federal and state level. In many cases, these are temporarily waived. And so it is important for us to know what was the situation, what was the case prior to COVID-19, because we are going to spring right back to prior state unless there's specific action that's taken to make these permanent. And a lot of our future practice will be shaped by which flexibilities are maintained. So with licensure, a quick true false, I won't do this as a poll, but for the duration of the national COVID-19 public health emergency, a blanket waiver for licensure has been issued for all 50 states and DC. Is this true or false? So right now we're able to practice in any state because of the public health emergency. And as much as I wish this were true, it's not. So generally, telemedicine and licensure, a clinician must be licensed in the state where the patient is located at the time of the telemedicine encounter. And for physicians, in addition to licensure, physicians must also stay compliant with a state's Medical Practice Act. So each state has a Medical Practice Act and practice standards. So the things that are covered there are, for example, patient examinations. How do you establish a doctor-patient relationship? How do you navigate remote prescribing? And then also there are some exceptions to this. This is the general rule. So there are special rules for healthcare professionals that are providing care through the VA. And this is due to the VETS Act of 2018, where if a practitioner is providing care through the VA system, they don't need to be licensed in the state where the patient is. It's due to something called federal preemption. There's also special rules for US military if you're providing care to a patient who's on a base. There are some compacts. For example, there's the Interstate Medical Licensure Compact. This was prior to COVID-19. This has been around since 2015. There's other professions as well. There's a nursing licensure compact specifically for LPNs and vocational nurses, not advanced practice nurses. That one, last I checked, was not active. Physical therapists also have a licensure compact. Psychology has been working on one as well. And then there's other exceptions, which I'll talk about, that are relevant to telemedicine. So the Medical Licensure Compact is an agreement between 29 states, DC and Guam. And my state, New York, is not a part of this. It's been proposed, it hasn't passed. It's a voluntary expedited pathway for licensure, but you still have to be licensed in each of the states if you want to get multiple compact licenses. So it's not like as long as you're licensed in one state, you're okay to practice in other compact states. You still have to pay the full fee and go through the process of licensure. It might make it quicker, but it's the same cost and the same amount of like CME requirements and other regulatory requirements for each state. And then compact states can share investigative disciplinary information. There's an additional fee for this compact, and you do have to have a full unrestricted license in one state in order to qualify for this. As I mentioned, there are some other licensure exceptions. These vary state by state, good for us to be aware of. Most, if not all states at this point, have at least some kind of consultation exception where an unlicensed physician can practice in a peer-to-peer consultation with another physician in a state without being licensed if they're not taking on that direct care of the patient. But each state is different in terms of how they define this consultation and what the limitations are. Some states will allow follow-up care. So for example, if a patient comes to, let's say, a surgeon to get a very specialized procedure, they go back to their home state. In about 10 states, that physician would be able to provide follow-up care without being licensed. Some states, this is not as popular now, but they have a special license specific for telehealth. And then there are a lot of regional kind of reciprocity. So bordering states will allow out-of-state physicians that are licensed in a neighboring state to practice in their state without a license. New York is proposing this with neighboring states currently, so we're still waiting to hear back about that. And then we get to current state. So during the COVID-19 crisis, each state has some kind of temporary licensure flexibility, but there is significant state-by-state variation. And these flexibilities are often tied to state-specific executive orders or emergency declarations. So they are expiring at variable times, which can result in abrupt severing of care. And it becomes very challenging to navigate state by state. One resource that's been helpful, somewhat helpful, is the Federation of State Medical Boards website. So they go state by state looking at what current flexibilities there are for licensure, what states are expediting licensure for recently retired physicians. So this is a useful resource to help track. American Psychological Association also has a resource for this. So just to mention one recent legislation that's been proposed to help address this complexity. There are others, but the TREAT Act which was recently reintroduced. It's bipartisan, and it would enable a healthcare professional. So it's not just limited to certain professions. It sounds like this one is more broad. So it would enable healthcare professionals in good standing who have a valid practitioner's license to render services, including telehealth, anywhere during the pandemic, during the public health emergency. And then it would also allow for a grace period. So licensure reciprocity with a 180-day phase out after the public health emergency is lifted. It would preclude any service that's otherwise prohibited by the state where the patient is located, and you would have to adhere to prescribing requirements. And it would allow healthcare professionals to care for patients from any state during this period without jeopardizing their state licensure. There are a lot of national organizations and individual hospital systems that are supporting this. So we'll see what happens. It didn't go through the first time. Now, with informed consent, there's often the question of what constitutes informed consent? What are the components of informed consent for telehealth? Do we have to get informed consent all the time? Is it best practice and we should? So when we're thinking through these questions, it is helpful to note that there may be state requirements that will require informed consent to be obtained for telehealth. Specific payers may have requirements, and then also our institution and organization may have requirements. So for example, in New York State, other than the New York State Office of Mental Health, which does require consent for telehealth, specifically for patients that we're seeing through the Office of Mental Health, there isn't any other specific requirement for informed consent. So in some of our settings, when we're treating patients in collaboration with the Office of Mental Health, we do get consent. In other situations, we don't necessarily get a formal consent. Informed consent best practices could include what you would include in there, things like services offered, the rights when receiving telehealth care, including the right to stop or refuse treatment. What are the potential benefits, risks, alternatives? Contingency plan, what would you do if the technology or equipment fails? It can include policies around billing and scheduling as well. And if we look state by state, this was prior to the pandemic, 39 states have some kind of informed consent requirement for telehealth. It could be part of a statute, administrative code, Medicaid policy. It may be a written requirement or a verbal requirement or both. And then how you would get it can also vary. So some may say you can get a standard consent without additional telehealth language. You may want to use you may have to use a standard consent with additional language or a completely separate informed consent. And then during the pandemic, a lot of exceptions have been made. So for example, in New York, the Office of Mental Health, New York State Office of Mental Health, we used to get a written consent for every patient before starting telepsychiatry. Now that has switched to verbal. And always good to check with individual payers as well. So controlled substance prescribing, I know we've worked very closely on this, Drs. Pruitt and Brooks and our committee on this issue related to telehealth. So the Controlled Substances Act was passed in 1970, and that act created the 5 schedules of controlled substances. The DEA, the Drug Enforcement Administration, was established in 1973. Since the Controlled Substances Act was passed, there have been about 11 amendments, and the Hyde Act, which I'll talk about from 2008, was one of the major amendments. I'll also talk about the Support Act and its relevance to this topic, and then some changes that have been made during the public health emergency. So Ryan Haidt, he was an 18-year-old. He died in 2001, and his parents thought that he was using their credit card to get baseball cards online, to purchase baseball cards. But he was on these internet prescribing pharmacies, and there were a lot of them that were proliferating in the 1990s, where you could pay a certain amount and you can get any drug, and without any physician oversight. There wasn't an assessment, evaluation. So he had overdosed on Percocet, Vicodin, and his parents, so his mom is a nurse, his dad is a eye surgeon, and and understandably they were very devastated. So they did a lot of advocacy. They didn't want this to happen to anyone. And those rogue internet prescribing pharmacies really were out of control at that time. So during that time, they worked at the federal level on some advocacy, and that led to the Ryan-Hyde Act of 2008. So the Ryan-Hyde Act, the primary goal, as I mentioned, was to combat these rogue internet pharmacies. And it definitely did a great job at addressing this issue, but unfortunately, it inadvertently limited the legitimate practice of telemedicine. And it requires, among other things, at least one in-person medical evaluation before prescribing a controlled substance. Now, there are 7 practice of telemedicine exceptions to this requirement for an in-person examination, but these exceptions are really narrow. They're technical, they don't account for much of current clinical telemedicine practice. And it is important for us to review, like many things I'll talk about today, it's not just about at the federal level, we have to look at our state rules, and federal and state may not always align, so it can become complicated. So one of the 7 exceptions, these practice of telemedicine exceptions, was a special registration. And it's been now 13 years, and the DEA has yet to define the special registration exception. Other exceptions would be if the patient is located at a DEA registered hospital or clinic, or if it's services being provided in the context of an emergency through the VA, or through Indian Health Services. So there are exceptions, but it doesn't really account for much of what we do. Now, that special registration has not been defined. The Support Act of 2018 had actually set a deadline of October 2019 for the DEA to define this special registration that's part of the Ryan-Hyde Act. The DEA missed that deadline. And in addition to this, that's the major component I want to focus on. But in addition to this, the Support Act also expanded Medicare coverage for telehealth services in home for substance use disorders or co-occurring mental health disorders, which was definitely a big win, because I'll talk a little bit more about Medicare, but pretty much before the pandemic, there were significant restrictions with Medicare. So geographic restrictions, there were only 8 or 9 types of practitioners that could qualify for reimbursement for telehealth. There were about 7 or 8 specific sites that patients had to be located in in order to be able to be reimbursed for Medicare. So it opened up in-home for substance use disorder and mental health disorders. So that's definitely helpful. And also, the Support Act would require a report from HHS on the effectiveness of telehealth for substance use treatment within 5 years. So some of the changes that we've seen specifically during the federal public health emergency, the DEA, they haven't defined the special registration yet, but one of the exceptions is a public health emergency. So during the national public health emergency, the DEA is allowing registered practitioners to prescribe controlled substances without this in-person exam, as long as you're prescribing for a legitimate medical purpose, you're acting in your usual course of professional practice, you're communicating using live interactive audio video, and you're also acting in accordance with federal and state law. And like I said, some states, federal and state don't always align, so some states may be more strict than this. So you may not be able to fully take advantage of this flexibility depending on your state. But it is certainly has been a very helpful change. Another issue, which I didn't mention, but is a big one for telehealth, the DEA typically requires that a practitioner have a separate DEA registration in each state where they're going to be dispensing a controlled substance. So that's been a huge limitation for telehealth as well. So during the public health emergency, there is an exception where you don't need a separate DEA registration in each state, in each jurisdiction. Specifically for medication-assisted treatment, the DEA also issued guidance in March on the use of phone for buprenorphine. So during the public health emergency, authorized practitioners can prescribe buprenorphine both to new and existing patients via telephone only, without needing to conduct that first in-person examination, as long as, again, similar language, you're prescribing for a legitimate medical purpose, acting in your usual course of practice, and it's your clinical decision making, you think you are able to do an adequate evaluation via telephone. So this has been very, very helpful as well. And then SAMHSA also issued guidance on methadone and buprenorphine provision for opioid use disorder in April, similar to what the DEA had provided, that you can use telephone only for buprenorphine, both for new and existing patients. But if it's a new patient with on methadone, you would not be able to do this without an in-person examination. But for established patients who you've already had an in-person examination with, you would be able to do this for both methadone and buprenorphine. So malpractice and credentialing, we can't always assume that our malpractice provider is going to cover our telehealth services. So definitely want to think through what questions we should be asking. If you're part of an institution like Maryland, like NYU, we have our legal and regulatory folks that navigate this for us. But for private practitioners, it's always something we want to consider. And then there's credentialing as well, which I'll talk about. So some of the considerations unique to telehealth when it comes to malpractice, if we may not always be in the same state. So a clinician and a patient may be located in states that have different laws, different statutes of limitations, the standards of care may be different, the damage caps can also vary across states. So you definitely want to make sure that your malpractice provider is aware of these and they will cover this in the other state. Many malpractice policies may exclude unlicensed activities, so it is helpful to know applicable state laws. They may say, well, we didn't know you were providing this care, so they may not always cover it. So they may say, it's okay for you to do this in another state, just write up for us what you're going to be doing. Or you may need an additional rider to your coverage. And I guess in some ways this is a good thing. There's very little case law to draw upon. We don't have a lot of malpractice cases with telehealth. We'll see how this changes since so many more folks are doing telehealth in the last year. But the case law that we do have involving malpractice, most of it is involving prescribing across state lines to a patient that's not previously examined. And the reason why I put that in quotes is because states may define that differently. What constitutes an examination, what technologies can be used, does it have to be in person? And if a state requires pre-existing doctor-patient relationship before you prescribe, you also have to look at how the state defines that. Can it be through video, or can you actually use other technologies as well for this patient examination? The one case that you may hear of when it comes to telehealth and malpractice was a psychiatrist, Dr. Hagaseth in Colorado, many years ago. He had prescribed or a college student at Stanford had gone on one of these online sites, filled out a questionnaire, was prescribed fluoxetine. So Dr. Hagaseth was the one who had written the prescription, but he didn't do an evaluation. He didn't do an like audio, video, or in person. It was prescribing based solely on an online questionnaire. That college student later did die by suicide. So there were legal regulatory issues that came up with Dr. Hagaseth. He was licensed in Colorado. The patient was in California, so it was determined that he was practicing in another state without a license. So what are some of the questions for malpractice carriers? To start, does my liability insurance cover these telehealth services that I am doing or that I want to perform? Is there an additional cost, or is a rider going to have to be added to the policy? Do you cover all states that I'm licensed in and provide telemedicine services to? Are there any technology standards or protocols that you recommend? Are my policy limits adequate in each state? Do you have any telehealth specific risk management advice? Many, if not all, do. And then it's always helpful to get written assurance of that coverage. So credentialing and privileging, telemedicine practitioners generally would have to be credentialed and privileged at all sites where they're providing care. This can be expensive, time consuming, it can be a duplication of effort. So I know definitely it's been my experience where I'm fully credentialed at NYU Langone, but if I provide services across the state at various psychiatric facilities, I have to go through the entire process of credentialing in each of those institutions, hospital systems, and it does take a lot of time and effort. So in order to help with the CMS and Joint Commission in about 10 years ago now, developed this credentialing by proxy process. It is optional. It has to be, in order to be able to use this, basically would allow another institution or hospital system to use the credentialing of another. So for example, if I am fully credentialed at NYU and I provide care in a hospital in upstate New York, that upstate New York hospital could potentially accept my credentialing at NYU, but there has to be a written agreement between the two parties, and sometimes folks are not open to that. So that can be a limitation. And the bylaws have to meet the requirements of this process. But when it works, and I've heard from from many folks that they have been able to use this, and it really has helped a lot. And also want to consider potential changes to credentialing and privileging during COVID-19. A lot of things were streamlined, or there were some things that were waived. So with privacy and security, as I mentioned, there's the technology considerations, and then there's environmental considerations. So with technology considerations, we would want to make sure that we're connecting using a secure point-to-point connection, that we have safeguards in place for PHI, private high-speed network, compliance with both federal and state laws and regulations, and also keep in mind they may not always align. We may have to follow whatever is more strict or stringent, fully encrypted data, and then business associate agreements. So if we are going to partner with third parties, making sure that they're also going to follow the rules around HIPAA like we have to as clinicians. And then there's environmental considerations. So physician and patient, making sure that we're in locations where no one can hear the visit, who should not be hearing the visit. So before I start any telehealth visit, whether it's a new patient or someone I've been seeing for years, I always start with, just so you know, I'm the only person in the room on my end, the door is closed, I have my AirPods on, and then that's a nice cue for me to say, what about on your end? Because I can definitely guide our discussion during the visit. And then you can have a patient pan the camera around the room if they were comfortable with that. Some patients wonder if a video visit is being recorded, is it going to go into the electronic medical record? So it may be helpful to let them know it's not, unless you are recording, in which case you would get additional consent. So some of the exceptions during the public health emergency, HHS Office for Civil Rights activated their enforcement discretion to say that they're not going to impose penalties during the public health emergency for clinicians that are not adhering with the regulatory requirements under HIPAA. If they're using these telehealth communication technologies for the good faith provision of care. So they specifically mentioned a few technologies that you can use, at least at the federal level. They're saying that they're not going to impose penalties if you use these. So popular applications like Apple FaceTime, Facebook Messenger Video, Google Hangouts, regular Zoom or regular Skype. But like I said, definitely have to look at what your state is saying and your organization. So for example, at NYU Langone, we had WebEx, we had Epic Integrated Video Visits, we have Cisco Jabber. So our institution said, even though at the federal level this is allowed, we're going to use our technologies. We're not going to use these. So you definitely have to look at that as well. And then OCR specifically mentioned don't use public-facing communication technologies, which makes sense, like Facebook Live, Twitch, and TikTok. So some considerations for documentation. For telehealth, generally is the same documentation requirements as those for in-person. Additional components, so states may require certain things, payers may, organizations may. So the location of the patient at the time of the visit, this becomes especially relevant if some of these flexibilities are waived, where right now in-home is covered for some payers. It may not be covered in the future, so they do want to know what the location of the patient is. The location of the physician, more to determine that the patient and physician are not in the same place, because then you wouldn't be able to bill for telehealth. So as a physician or other healthcare professional at a clinic, hospital, remote office, the types of technologies that are being used, you may have to document that. And then on both ends of the connection, who's present and their roles. So definitely helpful to consider ways to streamline that in the electronic medical record using templates or smart phrases. So some safety considerations during telehealth. If it's a patient that you were seeing in your in-person practice and then you transition to tele, not as much of an issue here for the first component here, but If you have a completely virtual practice, how are you going to confirm the identity of the patient and caregivers or guardian that may be involved in the care? We talked a little bit about ensuring privacy, environmental privacy, patient location and contact information. So especially over the past year, there have been a lot of situations where patients are not at home or not where they typically reside. So I know a lot of the college students that I see, they had to abruptly leave their dorms and they had to move out within like a week's notice. And so a lot of them didn't have any other residence in the state, so they had to go to another state to stay with family or friends. So always helpful to know what's the patient location and any contact information in case there's a disconnect in the technology or in case you would have to mobilize crisis services or there's an acute safety issue, because if you call 911 on your end, that's going to mobilize your own 911, not where the patient is. And then always having contingency plans for safety concerns. So having that discussion with patients regularly, just like we do with in-person, we're doing regular risk assessments. You may be appropriate for virtual care right now, but in the future, if you're not, we may need to refer you to either come in person to see us or to someone locally. And always helpful to have the local crisis line, the police department, and knowledge of local resources if it's not in the community where you are located. So the EDs, inpatient units. So for a lot of the care we provide in upstate New York, the sites are 2 to 5 hours or 6 hours away from us. So we work closely with clinicians on that end to navigate the resources that are available locally. And then, like I said, regular screening. If a patient is in a different jurisdiction, the civil commitment laws may be different. Consent requirements, confidentiality, the duty to warn or protect may be different, and then mandatory reporting requirements as well. And if a patient, like I said, is in a clinically supervised setting where there's healthcare professionals on site or other staff, we can collaborate with them. It's helpful to have, if possible, a direct communication method, like a secure chat, if you can do that during the video visit. I know that's been very helpful for me in some situations to communicate with the clinician. So reimbursement, and I won't do this as a poll, but during the national public health emergency, all public and private payers must reimburse for telehealth at the same rate as in person. Is that true or false? So are all payers now paying the same for tele because of the crisis? I see a few folks have said false. And facility fees, Heather, I see your comment. We can talk about that as well. So you guys are correct. I wish this were the case, but it's not. There's a lot of variability with payers in terms of what flexibilities they may or may not have right now. So telehealth reimbursement before COVID-19, and like I said, it is important for us to kind of have a sense of what the case was before, because we may spring right back. So before COVID-19, there was a lack of cohesiveness of policies, both within and between public and private payers. Still the case, I'd say. We have some things that have improved right now. So prior to COVID-19, like I said, Medicare had practitioner restrictions, service restrictions, geographic originating site. In 2019, they were starting to open it up a little bit and allowing telestroke to be done without that geographic restriction. So that was helpful for us in New York City. End-stage renal disease patients and substance use disorders, they were opening that up in some cases to being able to provide in-home care. And then storing forward, so Alaska and Hawaii have been part of federal telemedicine demonstration programs. So that was the case. With Medicaid, all 50 states and DC reimbursed for live video, but what exactly they covered was very different, and there were variable provider, facility, and service restrictions. Storing forward was reimbursed in about 11 states, remote patient monitoring in 20 states, and with Medicaid, every single state is different. With commercial insurance prior to COVID-19, about 42 states in DC had commercial insurance coverage laws, which said that commercial payers have to cover telehealth, but only 10 of those states had true payment parity language. So not only do you have to cover it, but you have to pay the same rate as you would if that service were provided in person. So only 10 states had that. Insurers also have flexibility to restrict telehealth depending on the contracts that they've signed with individual practices or organizations. And there was a question of facility fees. So prior to the pandemic, since patients for the most part had to be in certain locations, like there are 8 or 9 different types, or 8 different types of locations that the patients had to be located in, those sites could bill for a facility fee. So it's about $27 for use of that site and the technology. Now that we are providing care in home, my understanding is that CMS is saying that you can't bill for the facility fee if a patient is in home and they're not in one of those types of sites. So some of the changes, a lot of the changes that we've seen with Medicare over the past year, the geography limitation was waived, which for my institution has been really, really helpful across the board for chronic medical conditions, for virtual urgent care. So it definitely has been very helpful. So we don't know if that's going to continue or what aspect of it might continue. So it's really hard to expand the telehealth program when you don't know if you're going to be able to sustain it. The originating site limitations were waived, so we're seeing patients in home for Medicare. The types of modalities, so audio only, opened up a lot. So the reimbursement for phone increased, and then a lot of CPT codes we could actually use audio only for. There was a significant expansion of the eligible practitioners that could be reimbursed. There were a lot, actually more than 80 codes that were added for Medicare reimbursement. Licensure requirements were relaxed specifically for Medicare, but then they also said that you have to look at your state. So if your state doesn't allow it, you still wouldn't be able to use this licensure flexibility, but Medicare did allow for more licensure flexibility. Some supervision requirements were relaxed. Visit limits in some situations, they didn't have that limit around number of visits. And then communication-based technology services. So there were more codes that were eligible for phone, more asynchronous technologies, and they were able to do this by calling these communication-based technologies not telehealth. So they separated it out, and then that expanded reimbursement for other technologies. And then also allowing physical therapists, occupational therapists, speech language pathologists to be able to be reimbursed for telehealth. Now it's at the state level with commercial payers and Medicaid, it's state-based. So it's hard to kind of give specifics here, but these are some of the common changes we saw during the pandemic. So the modality, again, allowing audio only. Some states have made this permanent, but not others. Allowing home, relaxing the requirements around consent, as I discussed, expanding the types of services, just like Medicare, as well as the eligible practitioners, and then waiving some requirements for licensure. And this is a good website, the Center for Connected Health Policy, if you want to look state by state at what actions have been taken during COVID-19. With private payers, again, just like Medicaid, it is complicated. Some private payers may have made broad flexibilities during the pandemic, but really a lot of it is driven by what the specific states are saying. So most major private payers have expanded telehealth coverage, at least temporarily. Most issued cost share waivers for COVID-19 specific telehealth treatment. So that would include things like co-pays, deductibles. So most of them issued some kind of waiver to these. And many extended it not just to COVID-19 specific treatment, but also non-COVID-19 telehealth treatment, so primary and virtual care and behavioral health in some cases. And many agreed to reimburse at the same rate as in person, including for audio only, but not all of them. And then private payers kind of set their own varying expiration dates for these temporary telehealth policies. Many were set to expire by the end of 2020, so some have already expired. So this is also complex to navigate. And again, the Center for Connected Health Policy has great resources for this. So future. As we discussed, significant changes have been made in federal and state policies. And we're kind of thinking through which of these should be made permanent. A lot of national organizations have advocated for the following to become permanent: removal of originating site, distant site geographic restrictions, maintaining the expansion that we've seen of reimbursable services, and that true payment parity. So I mentioned before the pandemic, there were 10 states that had language about true payment parity for telehealth. It's up to 12 states now. And there are some resources on model language that states can adopt for this. Removal of requirement for in-person exam. So that's definitely a big one. Licensure, technology, and then, as I mentioned, the health disparities aspect as well is something that a lot of us are looking at now because it is such an important topic. So some pediatric telepsychiatry resources, I have a couple of more slides and then we'll open it up. So if you guys have any questions, please put them in chat. Our American Academy of Child and Adolescent Psychiatry has a telepsychiatry toolkit. Dr. Pruitt, Dr. Kathleen Myers led the development of this. And we have videos on key considerations in the practice of child and adolescent telepsychiatry. So we have about 19 or 20 videos at this point. We're continuing to expand the toolkit for COVID-19 specific considerations. So if there's anything in there that is missing, please let us know. The Telepsych website has guidelines, policies, links to other resources. As I mentioned, the pediatric telepsychiatry curriculum, which is online, national, open access in collaboration with Dr. DeYoung. In 2017, the Telepsych Committee of ACAP had worked on a clinical update in collaboration with the Committee on Quality Issues. APA also has telepsychiatry and COVID-19 resources that cover a lot of the things that we talked about. And then Center for Connected Health Policy, I mentioned American Telemedicine Association has done a lot of education and advocacy. This is a good resource, the National Consortium of Telehealth Resource Centers. There's 14 of them, 2 national, 12 regional. They're funded by HRSA. They provide guidance on setting up telehealth, expanding telehealth, legal, regulatory, clinical considerations. I reached out to them a lot, and they're a great resource. CMS, Center for Telehealth and eHealth Law, is involved with a lot of advocacy, and I mentioned FSMB. So thank you, everyone, for your time, and special thanks to our ACAP Telepsych Committee. So I have those folks listed here.
Thank you, Dr. Khan. I'll remind folks to feel free to send questions, post them in the chat. We have had a few come in. So some folks are entering them into the group chat and others are coming privately. Either is fine. I will just start. We asked for you to comment. Someone asked for you to comment on the length of session time that would be required for reimbursement for telehealth sessions, particularly with youth clients, with children and adolescents.
So I think there isn't anything different with tele versus in-person, depending on the CPT codes and the specific requirements that we would have, the amount of time for each of the codes. So I'm not sure if there is anything that would be unique to telehealth. I guess an issue may come up if you have a technology issue and you only are able to see a patient. Let's say it's a 30-minute visit, you're only able to see them for like 5 or 10 minutes and then the video goes out. You can convert to phone, but in terms of how much time you would need to get that reimbursed, I'm not sure what others have experienced with that, but that would be the only time where I think it would be different in a consideration depending on the payer.
We have another question here. Or do you have any thoughts about reimbursement or one-time setup costs to get clients set up for regular participation in telehealth visits?
Yeah, so one-time telehealth costs, and I mentioned the healthcare, the health disparities issue, and we saw this across our sites where those folks in certain practices, folks who had the technology, they had everything ready to go. We were able to maintain our practice with actually no decrease in visits. In fact, we saw an increase versus some populations, like some of the folks we were treating in upstate New York who didn't have access to the technologies. we either had to delay appointments or phone only. And, in some cases, school districts, for at least kids' school districts, were able to provide laptops and MiFis, so mobile Wi-Fi. In that case, we were able to continue, and actually those families ended up having the best connections of all my families once they were able to get the devices, and they were in the most remote areas. So I think there are ways, and we definitely need to think about how we can provide that technology and the training to set it up. And I think of both ends of the spectrum, pediatrics and our elderly population that we're treating, making sure that we also have that guidance on setting it up. FCC has a COVID-19 telehealth program, and it's opening up soon again. I think within the next couple of weeks, probably. I know NYU Langone had gotten some of that funding as well, and that was helpful to provide technologies both on our end in the hospital, but also for patients, the necessary technologies that would be needed. We definitely have to think about who's going to cover it. How do we make sure that folks have that? Otherwise, they're not going to get the access to care.
I'm interested, just since you mentioned the FCC funding, what type of equipment did you send home into patients' homes, and how has that gone? Did you send tablets or phones or laptops?
So combination, yeah. So tablets, a lot of it was a technology we had already, because you were able to backdate it to March, earlier in March. So a lot of it was a technology we had already deployed for the Epic integrated video visits. I believe some of it was remote monitoring as well for internal medicine, blood pressure scales, Bluetooth enabled, that would feed into Epic, where we, so I think that would be the other technology that it was used for.
Thank you. So a thank you, Dr. Khan, and then a question. Since the VA is already practicing across state lines, I'm wondering what are the pros and cons to that happening for other medical professionals outside of the VA, so MDs, NPs, social workers, nurses, et cetera. I'm sure it might be chaotic in some instances, but licensing is expensive and cumbersome. We also have a national shortage, which was a reality before COVID. So your thoughts on that comment and question?
Yeah, I mean, I absolutely agree. And the VETS Act was across profession, so it did cover all the professions that you mentioned, and it's kind of the gold standard of what would licensure look like if it were done well. Where as long as it's like a driver's license, if you have it in one state, you don't have to get it in other states. So I think it applies across professions with the VA. In the past, a lot of national organizations were not that enthusiastic about advocacy around licensure, because state boards they really want to be able to regulate the practice of medicine within their jurisdiction. So there's a lot of resistance to it. So generally, many organizations were not open to advocating for this, but now that's changing. So definitely now that we have all these flexibilities and we're seeing that it works well, APA is open to that discussion. APA is working on a policy statement that's still being reviewed on licensure, which I don't think would have gone through in the past, but now there are a lot of groups, AAMC, that's advocating for licensure flexibility, even American Telemedicine Association, because there was so much resistance in the past that I think they chose not to advocate for it as much, but that's definitely changed. So hopefully we'll see some movement.
So we have a question related to this, and you talked about some of it. But could you speak to what changes in telemedicine regulations you think are likely to remain post-pandemic, or what kind of landscape we're going to see?
Yeah, so that's the question we're all thinking through now, as we're also trying to focus advocacy efforts. I do think I didn't mention this, but MedPAC, it recently issued a report. So they often send reports to Congress making recommendations specifically for Medicare. And the reason why I discuss Medicare more than other payers is it's at the federal level, and often once Medicare makes changes, commercial payers and other public payers will follow suit. So that's what we definitely think a lot about what Medicare is doing. So MedPAC recently issued a report to Congress in March where they did make some recommendations on what they think should be made permanent. Among those were the originating site restriction removal, so patients being seen in home, geographic restriction, and they're not, all the recommendations they made were for temporary flexibility. So they're not saying make it permanent, but at least give us another year or two of this to see if it works. Some expansion of codes they also mentioned. They did not talk about the HIPAA flexibilities around like that enforcement discretion that I mentioned. So I don't think there's a lot of advocacy around keeping that, like allowing certain technologies that we are allowing right now, which I guess makes sense. Because I know during the worst of it all, it was really hard for a lot of individual like private practice folks or hospital systems to get that telehealth going because they were trying to reach out to all of the platforms. No one was responding. So it made a lot of sense right now. But whether that should be continued from a data privacy perspective, maybe not. So it makes sense that one may not be continued. And then licensure as well.
Well, thank you. We didn't tell you to bring a crystal ball, so we appreciate you trying to guess into the future. We're all working hard at that. So this is a question, Dr. Negro asks, DEA and state certification for controlled substance prescriptions require a local address. So what thoughts do you have about how to follow regulations post-pandemic when writing prescriptions across state lines if we don't have an office in another state?
Yeah, so that's the reason why so many groups were advocating to change that requirement, that you have to have an address in each state where you're going to be prescribing. Because if you're working through a telemedicine company, if they have an office in that state, perhaps you may be able to use that address. But if you don't have any physical location, it becomes tough. I've heard of some folks using like virtual addresses that you can get, but I don't know if the DEA has said anything about that. So I'm not sure if it's legitimate, but there are folks that are saying that you can get a virtual address in another state. So that's some workarounds that I've heard from some folks, but I don't know the details of that. And I don't know if the DEA has commented on whether that's allowed. Right now, during the public health emergency, we don't have to have separate registrations.
And a follow-up and maybe related from Dr. Negro, can we prescribe across state lines for those patients who were seen in Maryland but are out of state? So for example, if a patient's seen in Maryland and runs out of medications while on vacation or traveling, can we provide that refill?
Yeah, so I guess it would depend on the state and maybe the type of medication. So this has come up for some controlled medicines. If I've tried to send it in certain states or send it in certain states, it's allowed, but even certain pharmacies may say, no, we can't fill it. And then when you send it to another pharmacy, it is allowed. So it would depend on the state where the patient is at that time. If it's a non-controlled substance, or non-controlled medicine, I haven't had major issues. But with controlled meds, sometimes some pharmacies, specific pharmacies or states have said that we can't.
And then Dr. Khan, could you comment on maybe gaps or areas to focus telehealth or telepsychiatry research, kind of where you think the field is going or areas to focus there?
And I'd love to get Dr. Pruitt's input on this because he is a pioneer in our field. So would love to hear what your thoughts are on this. I'll start. I think we have a lot of data on patient experience, patient satisfaction. We have some on the provider experience, so there's some room there. I think the health disparities, which I discussed, is definitely a big topic. In terms of our advocacy efforts, so anytime we've worked with legislators, regulators, they're saying, where's the outcomes data? So, we know patients are satisfied. We know clinicians, once they try it, are satisfied, but is this going to be, at the very least, cost neutral, if not cost effective? So I think that's something we definitely want to look at. And then outcomes, are we, with providing care through telehealth, are we increasing access and also reducing things like emergency room visits, hospitalizations? And that's what they're interested in. They're saying, we have all these telehealth bills, but we're not letting them through because we don't have the outcomes data. Dr. Pruitt, anything you want to add?
You covered it pretty well. I think the pandemic has allowed us to really try new things. And I think trying to figure out now, as we move out of the pandemic, are those things working with tele? And the idea that you can get an extension of some of these flexibilities for a year or two, especially if you back it up with data. And I think the public health model is really critical that we follow, and certainly inequities in the healthcare system, rural areas, some of those are important.
And another sort of research-related question, is there an interest or necessity for teletherapy to be put to a clinical trial to compare to in-person treatment post-pandemic for indication/reimbursement purposes?
I think that's a great area. I mentioned the clinical update that the committee had worked on in 2017. That has a table that summarizes the pediatric telepsychiatry literature. So I think that's a good start to look at what's already been done in the last year. We have a lot more. We will see a lot more studies, but at least to get a sense of what's already been looked at. And a lot of those studies, they're helpful, but they are small sample sizes. I know Dr. Kathleen Myers had done the CATS trial for ADHD and telemental health. That was one of our bigger studies. But I think that's a nice kind of resource to look at, to think through what we should be studying. And I think what you mentioned would be wonderful to consider.
And Dr. Khan, could you clarify a stipulation you mentioned in your talk? In COVID, to protect clinicians, we have entertained having a patient in an office with the technology and then a clinician, say, on another floor in the same building and conducting a video visit. So both patient and clinician would be in the same physical location, like building, but could that be a billable telehealth visit?
Yeah, I'm not sure. I think maybe asking into the payer about that, because I know with Medicare, with a lot of the payers, especially post-pandemic, we may have some exceptions now, but they want to make sure that the patient and clinician are in a different location. So if it's within the same office, they may not cover it. I know with some of our other specialties, to limit exposure, like our medical students, they have a clinic that they rotate in. So they're doing some of the assessment by video, a lot of the history gathering, as much as they can by video, and they're next door to the patient, but then they'll go in for the physical exam for a much shorter period of time in the room. So I guess that they're probably doing as in person, but I'm not sure if it's completely virtual and you're in the same clinic, if that's going to be reimbursed. Generally, I'd say prior to COVID-19, no. So I don't know what they would say right now, but I think it's a great idea to think about models where you could do that, where maybe part of the assessment is by video if you need to see someone in person, they're close.
And a question, if your physicians or clinicians are practicing from their home and that model of any challenges with that? It's a brief question, but I think our team's interested in that model and how we make that, I think during COVID and beyond, something sustainable.
Yeah, absolutely. And that's come up with our clinicians as well, where especially with the stay-at-home orders, everyone's at home, you have entire families at home. So not just for our patients to be able to find a private space, but for our clinicians as well. I think that can be challenging. In terms of requirements from payers, of if a clinician is at home, does it matter? I haven't heard of any major issues with that. I know with our Medicaid in New York State prior to the pandemic, physicians had to be located in a Medicaid enrolled site, and that was waived. So now we are able to see patients while we ourselves are at home. The only major issue I've seen with payers, if a physician or other healthcare professional is in another country at the time of the visit, so Medicare and Medicaid, so I believe CMS generally will not reimburse for that if they know that the practitioner is out of the country. But otherwise, we are able to see patients while we're at home. And I think that it's also come up that, we're all in academic settings because we want to have our colleagues on site and collaborate with colleagues. So now, we're all virtual. We can still have some of that, but what does that do to the nature of what we do if we're not able to have our colleagues on site with us? It is nice to be able to kind of stop by someone's office throughout the day. So we definitely have lost some of that virtual. So I think just thinking through, there are definitely benefits for clinicians to be able to work remotely. There's flexibility, but If you are sitting in front of a computer all day, I like to mix up my visits when I was in the practice in person and virtual. Otherwise, you could be sitting for 8-9 hours in your day. So kind of thinking through video conferencing fatigue as well.
And another question about patients being in a different state or location, taking this to what if a patient is international? So the example was a patient calling from Ireland and needing guidance on a rash, lamotrigine rash, advice or guidance on that.
Yeah, so it becomes challenging. It might be institution specific if you have international telemedicine set up. For us, we don't provide care international, even if it's a established patient. There are considerations like licensure, malpractice, data privacy, and security as well. So with the European Union countries, there's GDPR, which was passed a couple of years ago, and I know Google was fined like, I don't know, 50-60 million for violating this. So it is, it's similar to HIPAA, but it's European Union specific. So you would have to make sure that the technology is set up to adhere to those requirements as well. So I think that becomes another factor with international. Some institutions, I don't know if Maryland is doing this, but are doing second opinions international if you're not taking on care of a patient, you're simply providing consultation or maybe reviewing records, not seeing the patient, but providing consultation. So there's some institutions doing that. But if you're taking on care, then the other factors might make it challenging, like the licensure. You may need to refer them to someone locally or emergency crisis resources locally.
Thank you. I think there's a couple questions I'm looking. I want to be sure I've gotten to all of them, but please be sure to add questions in if you have a topic that hasn't been covered. Dr. Khan, do you have thoughts of why the special registration was never done? Were there any consequences for missing the deadline? I see that one in the chat still.
I have a lot of thoughts about that. We've been talking about it on our committees for a while, that it's been 13 years and it should have been defined. There was that deadline. So we thought that there would be something that we would see in 2019. But when in our conversations with the DEA folks, they were saying anytime there's a change in administration, there may not be a lot of movement for several months leading up to that. So we were kind of prepared that they may not take action, even though there is that deadline. I'm not sure if there are specific consequences, but they did say that, well, back then when we had the discussion, they said that once they do propose something, they will open it up for public comment for at least 60 days, I believe, if not 90. Because when Reinhart first passed in 2008, unlike most situations, they didn't open it up for public comment. It kind of went through very quickly, which is not very common with these types of changes. So they said this time, once we do issue a special, like define the special registration, we are going to open it up for input. But again, that was like a year and a half ago. So I don't know what they're thinking. I do wonder. I think advocacy right now is really important because they may, there's that risk that they may make it more restrictive. And I believe the Biden administration recently appointed a new administrator for the DEA, maybe an attorney general from New Jersey. So I know our APA committee is looking at, along with the American Telemedicine Association, what advocacy efforts may be good right now related to this.
Thank you. And here is a question. Do you have any concerns about the shift to telemedicine?
So I think, yeah, we talked a lot about what flexibility should be maintained. I think there are definitely a lot of positives. I think our trainees getting the experience, whereas in the past it may have been just a subset of our trainees that got some telehealth experience. Now all of our trainees are, which is great. It does prepare them for their future practice. In terms of some of the potential negatives, so there aren't any absolute contraindications for telemental health. If we thought there were safety considerations, we may choose to have a patient come in person or a higher level of care. I think if we are all remote, I mentioned like the video conferencing fatigue, lack of access to colleagues if you are in a practice or an academic center. I think that would be some of the potential limitations. And there are some so some situations where it may be a little more challenging. So younger children, especially if it's a child with significant hyperactivity, if we're having even 20, 30-minute, 45-minute session, having them stay on screen, especially a younger child, it may be developmentally appropriate that they don't want to be on screen. But if you add like hyperactivity, ADHD, even more challenging, or autism spectrum disorder, some kids may actually feel more comfortable with the distance, but it may also be difficult to engage some children and adolescents with autism spectrum disorders. I think those could be some potential challenges. And the health disparities, are we excluding certain folks who don't have the access?
A sort of related question came in about effectiveness or looking at effectiveness of teleday programs. The comment acknowledges that some have seemed to pop up. I would expect this comment is referencing, during the pandemic, and then acknowledges also Zoom fatigue, as you just talked about. And just wondering if you have any insight or knowledge about the research on the effectiveness of such programs, IOPs, day hospital, utilization of programs like that. So if you could comment at all.
Yeah, I haven't seen a lot of data on higher levels of care, IOPs, day treatment programs, and Dr. Pruitt, not sure if you've seen much. I know a lot more programs are doing it. So I work at a day treatment program in upstate New York. It's since 2017. It's all remote. And I was concerned initially that we are going to start seeing children and families in home. It's a higher level of care. It actually has ended up working really well, especially once we were able to get technologies to families who didn't have access. We were able to kind of get a sense of interaction with siblings, get a tour of the room, kind of see the family together during a visit, which we don't always get to do. So it actually ended up working out, but we do need more data on those settings, how to do it well, when is it not appropriate to see a child or adult through video. And video conferencing fatigue, I don't think there's a lot of data on it. There's some resources on how to help with that, how to reduce that risk, but not a lot of data on this.
A question has just popped in. Do you agree that COVID actually forced us to advance 5 years in a few months when it comes to tele?
I don't think it was 5 years. I think it was about 35 years. Yes, I do agree. And I'm just thinking of like Dr. Pruitt and how you've been through this from the beginning, and to see all of these changes that you've been advocating for decades, to kind of just all those barriers drop.
Yeah, the pandemic really moved it really fast, maybe in some areas too fast, but you've done a wonderful job of drawing that together and looking at that from a really database point of view.
Thank you, Dr. Khan. I don't see any other questions popping in. We're near the end of our time, so if folks have a remaining question, feel free to enter it in the chat, or certainly unmute if you want to ask your question directly.
Great, and thank you so much for the invite. Great seeing everyone, and hopefully we'll meet in person.
All right, Rob, David, I think we, oh, Rob is saying he's unable to take himself off of mute. Rob was going to send us. There we go.
Okay, I didn't get the credential apparently. Thank you, Dr. Khan. That was wonderful. It's a pleasure to see you. And the only thing we miss is having you here in person, where we would have a lot more interaction. And we hope to have you back sometime in the future. Dave Pruitt usually springs for lunch and sometimes breakfast. You never know.
Looking forward to it.
Yeah. And I want to express thanks for our whole team, put this together, Anna and Dave Flax and Andre Jackson, our technical support team. We couldn't do it without you. So thank you very much. And Dr. Khan, it was a pleasure, and we hope to have you back.
Thank you so much.